Hello again, and welcome to another 5 minutes with Dr. Phyllis Murphie and myself, Adrian Zaka, and we're delighted to be joined today by Ryan Cheong from. Oh, tell me, Ryan, lead off. Tell us about yourself, sir. That horrid interview question.
No, it's a pleasure to be here, Adrian and Phyllis. So, as you know, my name is Ryan Cheong. I'm a consultant ENT surgeon. I'm based at University College London Hospitals at the Royal National Ear, Nose and Throat Hospital. So I'm a ENT consultant surgeon by background, and I subspecialize in snoring and sleep apnea.
Spot on. Exactly. Well, one of the two things that we're particularly interested in. So going on then a little bit more into the snoring and sleep apnea, what you mean, what, okay, I don't want to say what do you do, but I mean, so a patient just walk, they've been referred in for primary care.
Yeah.
They've come to see you. What now? What are you going to do? What are you going to do to me?
So the first thing I do is to take a thorough history of the patient. So initially want to gather as much information as possible to allow me to come up with a personalized plan for their snoring and sleep apnea troubles. Because as you know, Adrian and Phyllis, every snoring and sleep apnea patient is unique. Their circumstances are unique to them, and there's no real one-size-fits-all solution. And we can talk about that more in more detail. But essentially identifying if they have any of the common symptoms of troublesome snoring, witness pauses of breath by their bed partner, daytime fatigue or sleepiness, any issues of staying asleep or falling asleep, which may indicate elements of insomnia as well, will be included as part of the history. We then take a thorough, full broad range medical history about any other medical conditions the patient might have had, any previous ear, nose, and throat surgeries they might have had, and then we proceed to their social history, what they do for a living, because this may be relevant, especially if they are in a vigilance critical profession, any lifestyle risk factors, smoking, alcohol consumption, and then we move on to a thorough examination of their nose and throat to identify if there are any anatomical obstruction, any static obstructive anatomical features that may predispose them to snoring and sleep apnea symptoms. And after that, we then sort of tease down into the next steps that most suitable for the patient, including potentially a sleep study that will allow us to make a diagnosis of sleep apnea.
Brilliant. So I remember reading about drug-induced sedation endoscopy.
So the drug-induced sleep endoscopy, if you like to hear more about that, was actually pioneered at the Royal National ENT Hospital where I work. It was pioneered in 1991, and the whole idea behind the procedure was that if you wanted to identify a surgical intervention, potentially for sleep apnea or snoring patients, you first need to be able to identify where specifically, where and how they're obstructing whilst they're asleep. Because sleep apnea and snoring is a state-dependent condition. So the condition only manifests while they're in a specific state, which is sleep. So there is no point in examining the patient's upper airway to identify their point of obstruction during sleep apnea when they're awake. So we do this procedure known as a drug-induced sleep endoscopy. We bring the patient in, they have some light anesthetic, so it's not a full general anesthetic. So they are self-ventilating, meaning they are breathing. We watch them under controlled environments with a bespoke flexible nasal endoscope that allow us to identify specifically for them where and how they are obstructing. So some sleep apnea patients, they obstruct at the level of the palate, some it's the back wall of the throat, some it's the tongue, some it's the epiglottis, some it's a combination of these levels. So it's almost like a unique fingerprint, essentially, the way they obstruct. So we identify specifically for them where and how they're obstructing anatomically, and then we customize and tailor our treatment options based on their specific anatomy.
Fantastic.
Yeah,
Phyllis, you look like you're going to say something, so I'll shut up.
Say that I think for years we've missed a trick just in general in sleep medicine, that not having this whole multidisciplinary team approach where everybody and how often did the upper airway get ignored in the past, and only just concentrating on the obstruction here at this level and not what's actually going on anatomically in the nose.
Nasal polyps territory that's a favorite for your ENT.
If you think about it, obstructive sleep apnea is an upper airway disease. It's not a disease of the lungs. The lungs are fine. The actual point of obstruction is not the lungs or not the trachea. It's actually palate, the back wall of the throat, the tongue, the epiglottis, which is really within the realms of ENT anatomy.
It definitely is, for sure.
But for certain, you know, like we were talking about, there's no one size fits all, or shouldn't be. Let's put it that way.
Yeah. No UV triple Ps anymore.
So surgical intervention has moved and advanced significantly, and the main treatment options aim to, essentially, the first principle is to re-establish the upper airway during sleep. That's what all we're trying to do, to maintain the patency of the upper airway during sleep. So first line treatment option you'll be aware of, CPAP therapy, blows air into the nose and throat, almost acting like a pneumatic splint.
Yeah.
So 90% of the UK will offer this as a first line treatment option for sleep apnea patients. However, we do know that the non-compliance rate is around 34% as a minimum. So across 20 years of medical literature, we know that at least 34% of patients can't tolerate CPAP therapy, sometimes as high as 80%. So if you have a rough literature-based estimation, I know we're going to talk about the AWAKE study in a second, but literature-based estimation, 8 million adults in the UK have sleep apnea. If 34% can't tolerate the first-line treatment option, you're left with 2.7 million who don't really have a strong answer for their sleep apnea, right?
Yeah.
That's where we
completely agree. I mean, completely agree. I mean, he's diagnosed, you know, but what about the vast undiagnosed?
Yeah.
You know, the 80% that are estimated to be undiagnosed, which leads in very nicely to what we're trying to do with the AWAKE check.
Yep.
The AWAKE check is to try to get to the point where we have some comprehension of how big the issue is in the United Kingdom. Because Phyllis, I think that with the data was how old?
It was 2014, and it was Jorg Steyer who published in Thorax and looked at, it wasn't really UK prevalence, it was looking at the sleep centres across the UK, and then the British Lung Foundation did something in 2015, but we don't have good prevalence data. Adam Benjafield, who's part of the study team, had to really model the prevalence for the UK on his last publication based on other countries with similar demographics to us. So we don't have good data. So this is where we're edging towards.
That's what we're trying to do. Okay, I think we should stop there because I could love to carry on with this conversation, but 5 minutes, that's what we're talking about. See you in the next one. Thank you very much, Ryan.
Thanks very much.
See you again, Phyllis. Bye-bye now.
Thank you.
Thank you.
Bye.